This morning, I'm very excited to introduce Dr. Carley Zeal. Dr. Zeal is a hospitalist member of the ASOC division here at UW. She completed her residency training here and complex family planning fellowship at Washington University in St. Louis. Since training, she has worked in generalist roles and contracted to provide abortion services in various settings, including Planned Parenthood affiliates, private clinics, and recently the Hope Clinic in Chicago, one of the few outpatient centers providing abortion care for those presenting in all trimesters of pregnancy. Please join me in welcoming Dr. Zeal this morning.
Thank you for that introduction. As you said, my title for today is It's About Who We Are, Not When We Had Our Abortions. And so this is a talk about all trimester abortion care. And really, since most here are familiar with early abortion care, I'm going to focus on later abortion care. I have no relevant financial disclosures, but I do want to acknowledge that we're talking about a really sensitive topic that can be difficult to grapple with. Admittedly, as an early CFP fellow, I was secretly kind of glad that we didn't have the option of providing abortion care after 24 weeks of gestation because I wasn't really sure how I felt about it. So it can be a difficult thing to kind of wrap your head around. And I hope that this talk helps everybody kind of understand some instances where you might find it more acceptable or find it necessary. So the objectives of this talk are to introduce everybody to the who, what, where, and why of later abortion care, describe the procedure process, focusing more on 2 and 3 day procedures, describe barriers to care and strategies to mitigate these barriers, to discuss some strategies for maintaining person-centered care. And then throughout the talk, I'm going to present some cases to help us keep a focus on the people that we're taking care of. All of these cases are based on cases that I have either seen or heard about from friends and colleagues. All right, so in the spirit of keeping our focus on the people, I'm going to start with a case. So Jennifer is a 29-year-old G2P1 who is otherwise healthy with a previously uncomplicated term delivery. She had her 20-week anatomy scan that showed some questionable cardiac anomalies. She was referred to a fetal care center where a fetal echo was obtained at 22 weeks. This confirmed hypoplastic left heart. She had additional consultation with the geneticist and pediatric cardiologist, and after taking some time to consider her options in the setting of her planned and desired pregnancy, she and her partner decided on termination at 24 weeks, 3 days. The gestational age limit in her state is 22 weeks. So by the time that she could arrange transportation, childcare, a hotel, and time off, as she had her procedure scheduled at 25 weeks, 6 days. So let's start with the what. How do we define abortion later in pregnancy? It's kind of a trick learning objective here because that generally depends on who you're asking. Most of the time when we're talking about later abortion care, people are referring to after 20 weeks gestation. However, how you define late in pregnancy depends on the person. But we do need to make sure that we're using the correct terminology here. The preferred terms are abortion later in pregnancy or later abortion, and definitely not late term abortion. Late term is a separate medical definition, and that's not what we're talking about here, and it just confuses things. This is medical care, so we should make sure that we're using the correct medical terms. And we absolutely do not say abortion up to the point of birth. To put this kind of care into perspective, I think it's important to think about how often these procedures take place. This figure is from the CDC and is from data from 2022. It can be a little bit difficult to specifically count abortions in the US since post-Dobbs because there are more and more abortions happening through telehealth and through self-managed abortion. However, we can see here that most abortions that were counted in the US in 2022 took place before 13 weeks gestation, and less than 1% occurred after 21 weeks. So patients seeking care later in abortion are a relatively small population. This figure is from the Guttmacher Institute, and it also illustrates well how most abortions are occurring early in pregnancy, with more than half of abortions taking place through medication abortion, which is in the first trimester. Now let's get a better understanding of who the patients are that are seeking abortion care. The following statistics are all on patients seeking all abortions. So more than 2/3 of those patients were in their 20s, so more often younger. And in fact, adolescents make up 10% of them. Similar proportions identified as Black, Latino, or non-Hispanic white. More than half had previously had a birth. And 16% identified as non-heterosexual, with more than 1% reporting their gender as something other than female or woman. So a disproportionately large population there. Also, 41% had an income level below the federal poverty level, which is also a disproportionate amount, considering the census data tells us that 11.1% of people live below the federal poverty level. So finally, approximately 1 in 4 women are expected to need an abortion by age 45, and that's based on data from 2020. To help us understand a little bit more about those specifically seeking abortion later in pregnancy, we have data from the Turnaway study. This Turnaway study was a large groundbreaking study that looked at people seeking abortions close to gestational age limits in their regions, and then compared 2 groups, those who were able to obtain the care that they needed and those who were turned away. Unsurprisingly, the study found that people who were denied the care they needed had worse outcomes through several measures, including educational attainment, financial status, emotional well-being, and relationship safety. The study also found that people who needed abortions at 20 weeks or later were overrepresented by the following groups, and some were part of more than one of these groups. Those included people raising children alone, people who were depressed or using drugs, people in conflict with a male partner who are experiencing domestic violence, people who had trouble deciding and then faced access problems, and people who were young and nulliparous. I want to take a moment to acknowledge the myth that people just wait around until the last second and decide that they need an abortion later in pregnancy. It's simply not true and only serves to incite negative feelings against people seeking later abortion and those who are providing it. And it even incites some violence against them. The factors that make it more likely that someone will need an abortion later in pregnancy are correlated with institutional and systemic inequities, yet they're often cast as personal failures instead of signs of larger systemic issues. We'll kind of take a step back and talk about another patient. Beth is a 40-year-old G3, P2, seeking abortion at 28 weeks. She presented for a routine OB visit, reporting generalized malaise and had not gained weight since her last visit. She also noted a breast lump on her review of systems. She underwent extensive workup and ultimately was diagnosed as stage 3 breast cancer. Oncology and MFM counseled her regarding the next steps, and chemotherapy was recommended. After weighing risks and benefits, she prefers to initiate therapy for her breast cancer before she reaches term in pregnancy. She and her partner are concerned about managing her care and the care of a preterm infant, as well as the care of their 2 young children. They live in a small rural town and they're living on a single income. They had been excited to welcome another child, but with all of the challenges ahead, they're worried that they won't be able to handle it mentally, emotionally, and financially. So why do people seek abortions later in pregnancy? There are 2 common pathways by which most people end up needing abortion later in pregnancy, and sometimes people experience parts of both. The first pathway involves new information. This can be when a patient learns a piece of information that made them realize that this was not a pregnancy that they wanted to carry to term. This includes things like health issues related to the pregnancy, either the pregnant person or the fetus, or unforeseen events or new life circumstances, or late recognition of the pregnancy. We'll come back to that. The second pathway includes barriers to care. Studies show that when a person decides that they need an abortion, they would like to have it as soon as possible. Things like restrictions, including funding bans, travel costs, childcare, and conflict with others about their abortion decision, can introduce significant obstacles. These obstacles compound one on another and push the person further into pregnancy. In our post-ops world, there are more and more barriers than ever. And so more people who would have preferred to obtain an abortion earlier are pushed later into the pregnancy. So some might wonder, with all of the advancements we have in diagnostics and prenatal care, how a maternal or fetal diagnosis could be missed until later in pregnancy. However, there are plenty of instances that result in late diagnosis of either maternal or fetal health complications. Sometimes people have a questionable fetal diagnosis and follow with additional testing or ultrasounds. And by the time they have a diagnosis of something that is either life-limiting or lethal, it's too late for the gestational age limit in their region. When it comes to maternal health complications, sometimes a late diagnosis is related to limited access, or they may have a known maternal comorbidity that was stable initially and becomes more of a problem later. Jenna is a 29-year-old G1 who discovered her pregnancy at 21 weeks. She's amenorrheic due to a combination of her thyroid disease and continuous use of contraception. She had been advised by a provider that she should not take her birth control pills in the morning with her Synthroid, so she adjusted to taking it in the afternoon, but that resulted in it being more difficult for her to remember her pills. She knew right away when she found out that she was pregnant that she would want an abortion. She scheduled at a local clinic who did a pregnancy test, ultrasound, and counseled her. She thought it was strange that they focused on parenting and adoption and ultimately didn't offer any abortion services at that site. However, they told her she had time to decide. She scheduled herself at another clinic and was too far along for the state limits. She finally was able to arrange her care at 27 weeks out of state. While people have abortions later in pregnancy for many of the same reasons that they seek earlier in pregnancy, people seeking abortions later in pregnancy often do not discover their pregnancy until further along. This happens for any number of reasons. Some folks don't have symptoms of pregnancy. Denial can be a pretty strong monster. People have poor access to medical care and abysmal sex education. This graph is again from the Turnaway study and shows weeks since LMP on the x-axis and abortion by gestation on the y. For early abortion prior to 14 weeks, people took an average of about a week to discover the pregnancy, a week or less to make their decision, and about 2 to 3 weeks to find and get to a clinic. For people at 20 weeks and up, on the other hand, the time needed to discover the pregnancy was more than 8 weeks, with another 8 to 10 weeks to locate and get to a clinic. The options for abortion at 20 weeks or later are extremely limited, particularly in our post-ops landscape. It's crucial to make connections between the reasons for needing later abortion care and structural inequities that harm specific groups of people. Young people, LGBTQ people, Black and brown folks, people living in poverty, and people with disabilities are more likely to have difficulty accessing medical care in general, and particularly abortion care, which is so restricted. Abortion bans, particularly abortion bans on care later in pregnancy, disproportionately impact these groups that have already been and continue to be historically marginalized. I also want to specifically mention the role of crisis pregnancy centers here. It's been well documented that CPCs, in an effort to prevent people from having abortions, will give people misleading information about their gestational age. CPCs aren't regulated like clinics, and it happens frequently at abortion centers that we see very poor ultrasounds for dating from a CPC. One well-known tactic is to underestimate the gestation and tell a patient that they have time to make their decision when really they are close to gestational age limits in their region. The next case is Ava. She's a 14-year-old G1 who has always had irregular periods, pretty normal for a 14-year-old. She wasn't aware of pregnancy symptoms to recognize. She thought she had been having intermittent light periods. She presented to her primary care doc for abdominal pain and had a positive pregnancy test. Her ultrasound showed she was 27 weeks. We may all be thinking that she and all those other patients that we've seen who didn't know they were pregnant were in some pretty impressive denial. That may be true, and it may be obvious from the outside that they are pregnant. However, in their own reality, they're coming to terms with a new diagnosis of pregnancy in the here and now. And it's hard to understand why someone who recognized their pregnancy early on in pregnancy should be provided with the full options counseling, or somebody who recognized their pregnancy later on suddenly doesn't have the option of termination. The outcomes at the end of the pregnancy are the same for those two people. In addition to financial and logistical barriers to access an abortion facility, people also delay care because of an inability to share their plans with their support system or because they are afraid of rejection, someone obstructing their care, or even violence. The post-op legal landscape has made accessing an abortion facility much more difficult, depending on the state in which you live. In 2020, 9% of patients seeking abortion care had to travel out of state for that care. In 2023, that number was up to 17%, or 166,000 patients seeking abortion care needing to travel out of state. Another factor is that there are more and more hospitals that are now affiliated with religious institutions that don't offer abortion services. These facilities may also regulate their providers on options counseling and referrals. And from personal experience, like in Wisconsin, I can say that even hospitals that aren't religiously affiliated are unwilling to provide abortion services and are uncomfortable with hiring a provider who's committed to that care. Lastly, the threat of violence is very real and getting worse. The National Abortion Federation keeps track of violence and harassment statistics and reported in 2022 that there was a 229% increase in stalking, a 25% increase in clinic invasions, and a 231% increase in burglary compared to 2020. The most recent reports from 2023 and 2024 demonstrate a sustained and consistent acts of violence. But they acknowledge a difficulty comparing year to year because of the closures of so many health centers, and those that remain open have decreased their reporting because they're too busy with clinical care. Since we're talking about a lack of providers, this map shows the clinics that currently provide abortion care beyond 29 weeks. There are other clinics that provide care beyond 29 weeks, but either don't list it on their website or sites like ineedana.com, or they only provide that care under certain circumstances. So the places that we have are Partners in Abortion Care, which is in Maryland, and they provide care up to 34 weeks. DuPont Clinic in Washington, D.C. that provides care up to 32 weeks. Care Clinics also in Maryland that provides care up to 35 weeks, 6 days. The Rise Collective, which people may have heard of, the Boulder Abortion Clinic. This is the newly opened Boulder Center. And they provide care up to 32 weeks. The Valley Abortion Group, which provides care up to 34 weeks, and then newly the Hope Clinic in Chicago that provides care up to 34 weeks. There are a handful of other clinics that provide care between 24 and 29 weeks. And certainly there are individual clinicians and hospitals that provide care after 29 weeks, but oftentimes those are in very specific circumstances. As far as freestanding clinics that specialize in all trimester care, this is it. Lindsay is a 28-year-old G4P1 who was able to schedule and arrange travel for her abortion care at 30 weeks and 1 day. She's known about her pregnancy since she was 10 weeks pregnant and has been decided on termination that entire time because she's in an abusive relationship. She has limited use of the phone, her vehicle, and relatively limited communication aside from caring for her other child. It took her several weeks to arrange a doctor's appointment at all, and then she needed additional time to arrange her finances, transportation, and childcare. She also aligned this with seeking care to leave her partner. She feels like if she continues this pregnancy, her partner will have an additional hold on her. Now that we've talked a little about the what, who, and where of later abortion care, we'll move on to how this care is provided. I'm going to leave a caveat that I'm going to keep this pretty surface level without a ton of detail, because I don't think that everyone here is seeking to provide third trimester abortion care, but I think it's important to understand how it occurs to help counsel patients. We'll start with preparation of the patient for outpatient later abortion care. All patients do a phone intake to screen for medical conditions, history of uterine surgery, and other practical support needs. This will help identify if somebody needs a more detailed ultrasound or if they may have medical conditions that would limit outpatient services. All patients receive ultrasounds to confirm gestational age, assess the placenta, a hemoglobin and RH status. We also screen all patients for any signs of coercion, ambivalence, or intimate partner violence. They then have a detailed counseling visit and consent for the process, reviewing the steps in detail, as well as reviewing sedation options and expectations. The next two slides are very information dense, and I'm sorry for that, but I think it lays out well the process of providing this care. This is a common protocol for a 2-day D&E for anybody 18 to 26 weeks. The line at which you decide on a 2-day versus a 1-day procedure is blurred depending on both provider comfort and patient factors such as parity and history of C-sections. Other considerations in a 1 versus 2-day procedure include the clinic flow, requiring more space and staff for longer cervical prep time, and the ease of the procedure for the surgeon's longevity. On day number 1, most people receive 200 milligrams of mifepristone orally, and osmotic dilators are placed, usually a combination of dilapan and laminaria. The use of mifepristone is also something that is provider dependent here. Many clinics providing outpatient abortion at these gestations have decided to provide feticidal injection for any patients 22 weeks and over. The reason for that line is that 22 weeks is where many hospitals would resuscitate, and we want to avoid a live birth if at all possible if they end up presenting in between at a hospital. There are 3 different options for feticidal injections. One is 1% lidocaine intracardiac, and then there's KCL intracardiac, or digoxin intrafetal or intraamniotic. A lot of people use lidocaine primarily because of its safety profile and because it's non-specific to abortion. So as much as we would like to believe that all of our patients are going to follow all of our guidelines and stay nearby, at some point, some patient may leave and end up presenting in another state where there are laws against abortion with a demise. If that person has digoxin in their system, that might seem more suspicious for an abortion procedure. Whereas lidocaine is very non-specific to abortion and wouldn't tip anybody off that anything had happened. It's not something that anybody likes to think about, but that's the world that we live in. The patients that are going home also get a take-home bag of ibuprofen, Tylenol, and Zofran, as well as a phone number to call 24 hours. At Hope Clinic, there's a team that's on call throughout the night. The phone line goes directly to the primary provider, and then you can call in a team if someone ends up needing to come in to have their procedure overnight. We also give them misoprostol to take before day 2. On day 2, the patient receives their misoprostol buccally or vaginally. They wait anywhere from 1 to 4 hours, and they have a standard D&E with sedation. They receive 1 dose of antibiotics and spend a half hour to an hour in recovery. We also offer cabergoline for lactation suppression and contraception if they desire. For patients between 26 and 34 weeks, most providers do a 3-day induction abortion. On day 1, patients receive 200 milligrams of mifepristone, which has been shown to shorten the time to delivery in a multiple-day induction. They also receive a feticidal injection. Patients get the same take-home medications and phone number for overnight. On day 2, they receive pre-medications and have osmotic dilators placed. We typically place between 4 and 6 dilators, and again, a combination of dilapan and laminaria. On day 3, patients undergo labor induction. After placing an IV and administering sedation, we remove the dilators and rupture membranes and place a paracervical block that includes lidocaine, Toradol, and Dilaudid. This offers a longer lasting pain control, and most patients are able to rest relatively comfortably while they're laboring. And once they get to a point of having pain that is not like tolerated well, they're usually at the point that they are ready for their procedure. They also, while they're laboring, receive misoprostol 200 to 400 micrograms every 2 to 3 hours. The lower dose is for patients with a prior cesarean section. If patients have less than optimal dilation at the time of AROM, then we would also consider placing a Foley balloon at that time. The length of induction varies greatly across patients, but most patients end up delivering during the daytime before or about 6 p.m. When it's time for their procedure, patients are brought to the procedure room and given sedation. Generally, patients do not have to contribute any effort for the procedure. There's no pushing unless they want to. We effect the delivery by helping from below by placing traction on the presenting part and sometimes decompressing the calvarium. We do a gentle suction following delivery of the placenta. Most people spend an hour and a half to 2 hours in recovery, and they're given cabergoline for lactation suppression and contraception if they desire. Our next case is Mary. She's a 32-year-old G2P0 who was initially referred to an MFM locally for an abnormal ultrasound at 20 weeks, 5 days. She was told that the abnormalities were of unknown significance and was advised to return. She had another ultrasound at 22 weeks, 6 days, and it was at that point she was referred to a fetal care center with a fetal surgeon for a myelomeningocele. She had her consult with a fetal surgeon at 23 weeks, 6 days. It was at this point that she had her first discussion of the severity of the myelomeningocele and options counseling, including termination. What she didn't know is that her MFM, who she still trusts, has been known to avoid referrals to the fetal surgeon before 22 weeks, which is the gestational age limit in her state. He states, "My patients aren't looking for that option." Ultimately, she decided on termination, but was beyond the state gestational age limit and needed to arrange travel, time off for her and her partner, and was scheduled for her abortion at 26 weeks. Pain management options tend to be a little bit different in the outpatient setting. However, I can say most patients are able to achieve relative comfort throughout the process. For the dilator placement, removal, and procedure, often some level of sedation is provided, usually a moderate sedation. This may include some combination of fentanyl, midazolam, ketamine, and dexmedetomidine. Some clinics do have capabilities to provide deep sedation with propofol, but that requires an anesthesiologist support. As stated previously, we also provide a paracervical block. After dilator removal and AROM, we provide a paracervical block with lidocaine, Toradol, and Dilaudid, which has longer lasting effects for the labor process. There are also options for lidocaine gel and doula support, and some of that doula support is formally trained doulas, but also many of the patient care assistants are trained in abortion doula. I provided here a list of medications and dosages used for moderate sedation. This is from the National Abortion Federation clinical guidelines. We often use fentanyl for pain, and we do often start with a 50 microgram incremental dosing because we're combining it with midazolam and ketamine. It's important to note that ketamine is contraindicated in patients with hypertension, and the most common adverse reaction to ketamine is a psychosis, which more often occurs as they coming out of the medication. There's not really a treatment for that psychosis. We generally just have to support the patient through it. But the best way to avoid it is to co-administer ketamine with a benzodiazepine, which we are often using midazolam for that. The medication that's not listed here is dexmedetomidine, which helps with analgesia and anxiolysis. It's an alpha-2 adrenergic receptor agonist, inhibiting the release of norepinephrine and terminating propagation of pain signals. It can also cause bradycardia and vasodilation, so that's something to be aware of. It helps enhance the aesthetic properties of the other meds without causing additional respiratory suppression. The initial dose is 25 micrograms, and you can do incremental 25 microgram doses up to 200 micrograms. It's infrequent that we really need to go beyond that first 25 micrograms. An important thing to discuss is the risk associated with labor abortion. We can't consent a patient to a procedure without fully informing them of the risks of that procedure. A lot of the information we have about risks of complications is extrapolated from early abortion procedures as well as labor birth data. The overall risk of serious complications during a D&E is approximately 1%, but that risk increases with gestational age. The risk also increases with provider inexperience, which can sometimes cause some access issues. Again, these procedures are not particularly common, so having an experienced provider locally can be a challenge. Risk of complications for labor induction abortion is probably closer to the complication rate for births. However, outpatient abortion providers aren't providing care over 35 weeks, 6 days, because we see many of those risks increase sharply towards the end of pregnancy, such as hypertensive disorders, etc. Since we're using misoprostol for induction, we do think about the risk of uterine rupture, particularly for patients with a prior cesarean section. For this reason, patients face some limitations for induction abortions over 28 to 30 weeks if they've had a prior C-section. There may still be the option of a D&E if they desire that for those with later gestations. Patients with prior cesarean sections also require careful assessments of the placenta by ultrasound for signs of accreta. Other measures to manage risks include stocking multiple uterotonics as well as Abacri and Jada devices to treat hemorrhage. All of the clinicians and registered nurses in the Hope Center are ACLS trained. And then we conduct regular hemorrhage and other emergency simulation drills to keep everybody ready. In fact, the first time I was at Hope Clinic, I was part of a drill. Finally, all sites maintain strict criteria for eligibility for who can complete a 3-day procedure in the clinic. A medical history that would make someone ineligible for a birth at a freestanding birth center will also likely make them ineligible to complete a 3-day procedure in the clinic. If there is ever any doubt about the safety of a procedure, we generally err on the side of caution and don't provide it. For those who don't qualify for an outpatient abortion procedure, we do have the option of a fetal injection and return to an accepting facility for labor induction. How this is handled at the receiving hospital is at the discretion of the receiving clinicians, with as much or as little documentation as they need. There are limitations to this depending on the state that they're going to, so we wouldn't provide this to someone going back to a state with aiding and abetting laws. Our final case is Tanisha. She is a 23-year-old who has had a renal transplant. She has a desired pregnancy, and despite her counseling from her primary provider and her transplant provider, she stopped her anti-rejection medications out of fear of the effects on her baby. She was admitted at 24 weeks with renal tract retraction and HELLP syndrome, and with a new diagnosis of FGR with an estimated fetal weight less than the first percentile. Due to worsening blood pressure control, renal function, and labs with her platelets and LFTs, she had been counseled that delivery was indicated for her health and safety, but the prognosis was very poor for her fetus. She fears a very short yet painful life for her baby and is opting for termination. To help everybody understand provision of this care, it's important to consider the logistics outside of the clinical care. The vast majority, at one center over 90%, of patients require some assistance with funding and practical support. Most patients are traveling long distance and very few insurance plans cover abortion, but there are plenty of options. There are abortion funds throughout the country and practical support organizations. Some centers have their own social worker and staff just for arranging this care. There are often agreements with local hotels and organizations or volunteers that help with transport to and from the facility and to airports, etc. And some also use Uber Health. The point of showing all these organizations is to say that you should never let cost stop a patient from seeking the care that they need. If you're encountering one of these patients and you're sure they don't have the resources to travel across the country or even to Chicago, don't let that stop you from giving them the phone numbers. Encourage them to call, because these clinics that all have people that will help access whatever resources might be available. I also want to highlight some of the things that we do to maintain patient-centered care. Every patient deserves expert care and dignity throughout their care, which requires us to acknowledge the complexities of persons' lives surrounding their road to this space. Things we can do to increase person-centered care include allowing the partner or support person to be involved as much as possible, providing abortion doulas, offering keepsakes to everybody, coloring books and art supplies in the waiting areas, and journals in waiting areas. Some of our person-centered care requires support of outside organizations to support patients before, during, and after their abortion. Some of these include religious communities, volunteer student groups, care package donations, and gift card donations. As for keepsakes for patients, we offer keepsakes for all patients, acknowledging the complexities of emotions around abortion decision-making and relationships with the pregnancy. Some keepsakes include ultrasound pictures, footprints, hats and blankets, memory bags, photos. Most also offer private viewings of fetal remains. The staff are trained in preparation of the remains, and they prepare the patients and their support person for remains from an induction and from a D&E procedure. Clinics also make funeral home arrangements when desired. Sometimes there are negotiated prices for cremation and shipping of the remains, and it may require that the clinic fill out a fetal death certificate as well. I'm sharing here some photos from Hope Clinic Chicago. The first is an example of a keepsake box for a patient. It includes an envelope for footprints and handprints, a blanket, a little stuffy, a candle, and an envelope of seeds to plant in remembrance. They will also often add a box with clay molds of hand and footprints. The second is a journal that is held in the recovery area for patients to share stories, experiences, and words of encouragement. Thanks. I can't provide pictures without a HIPAA violation of their words, but I can say the stories and words are truly inspiring. There are a few books out there that have published some of these stories of patients and some of the exact words from journals like these, and they are really worth reading. I want to conclude this talk with a brief word about viability bans. In the reproductive advocacy space, we've had a lot of talk about strategies to protect abortion access state by state. And many states are working on ballot initiatives to enshrine abortion rights into their state constitutions. Some states have included viability language into their ballot initiatives. Typically, that's a ban after viability with some exceptions. And that's to gain more public support. But recent opinion research shows that viability bans don't need to be included in order to garner public support for abortion rights. In fact, viability language received less support in the opinion research than bans that did not include viability language. We know that fetal viability is a clinical determination and is unique to each pregnancy. And viability bans fail to recognize the role of clinical judgment and each patient's unique circumstances. Criminal penalties for violating these bans make clinicians fearful of being able to provide evidence-based care when it is needed. Every time we draw a line in pregnancy and say no more abortions after this point, we will harm people that fall on the other side of that line. Exceptions, even when they're broadly crafted, make the assumption that legislators know more about the clinical care than the providers and about the patient's circumstances than the patient themselves. The silver lining in the Dobbs decision cloud is that we have the opportunity to work towards something better. Using post-viability abortion as a bargaining chip with people whose goal is no abortions at all is harming groups of people who can least afford to be further harmed. Remember who's disproportionately affected by later abortion: children, people experiencing poverty and violence, Black and brown folks. The last thing people need when they find themselves in the position of needing later abortion are bad laws made by willfully ignorant people that come between them and their ability to get the care they need. If we don't think we can pass a ballot initiative without viability bans attached, then we're not ready to pass the ballot initiative at all. We need to do a better job of educating our voters. The anti-choice movement has been at this for a long time. It took 50 years for Roe to fall. However, the arc of the moral universe is long, but it bends towards justice. We are also in this for the long game, and we need to have a goal of what's right for our patients. In summary, later abortion care is important and safe care for a small and vulnerable patient population. As reproductive health care providers, it's our job to support our patients and assist them in obtaining the care that they need. Legislative and logistic barriers are large, but they're not insurmountable, which is all the more reason for us to advocate for patients.
We have time for a question or two.
Thank you so much, Carly. I really appreciated this presentation. One of the things that I was most interested in is how you started with your own ambiguity around this and how that's been part of your orienting toward abortion later in pregnancy. Would you be willing to talk a little bit about that? Your ambiguity, how you've grappled with that? I think we can all relate. Many of us can relate to that. So I'd love to hear more.
I think we have a focus, we come into medicine with this focus of taking care of our patients. And in residency, our focus is a lot on taking care of the pregnancies and delivering healthy babies. And there's always a little bit of a push and pull and a kind of discomfort with providing abortion care near that ability, because as residents, we experience providing abortion care at the same gestation that we are talking to a patient about how can they save their baby. But I kind of came to terms with those two things, understanding that like those two patients and those two pregnancies are totally separate things. That the person who wants every last measure to save their baby is in a different space than the person who can't continue their pregnancy. Additionally, people who are deciding that they can continue the pregnancy, that doesn't necessarily mean that they don't want the pregnancy. And that's another thing that you have to kind of understand and come and meet the patient where they're at. And I think it was through providing more and more abortion care that I came to understand that those feelings are very different and we have to meet the patient where they are.
Yes, Carly, thank you so much. I really appreciate this presentation because it gives some really important information to our OBGYN community. And it's not necessarily information and care that we're in, day out. So I really appreciate that. And I appreciate your ability to answer Jenny's question, because I think that's a difficult question. And many of us struggle with this, and we know so much about OBGYN. How do you think we can help our wider medical community and our wider society to understand this complexity? Because you know, one thing I keep saying is pregnancy is really, really complicated. And we want to provide patient-centered care for every single person. And as you said, 1 in 4 people are going to have an abortion by the time they're 45. The same people who are bearing children are the same people who are having abortions. And so how do we help people understand this complexity? You did a great job today in, you know, in an hour talk with multiple key cases, but I know it's a big question, but I just would love to get your thoughts on the advocacy part.
So a lot of people in the advocacy space do like to focus on stories of patients. I kind of grapple with that sometimes just because I feel like a lot of times it's focusing on certain cases and like these are the good abortions, and then people think like anybody else for any other reason is just like, oh, those are just those other people getting abortions. Whereas I like to understand that all of my patients have valid reasons for their healthcare decisions. And it's often influenced by things that I have no idea about. So that is kind of challenging with making the broader population understand these decisions. But I do think stories do tell a lot to help people understand that these are everybody, that this can be any patient, and emphasizing to the broader community that we take care of people who want to have babies and who can't have babies. And all of those people are the same people.
Thank you so much.
Carly,